Abnormal psychology is a division of psychology that studies people who are abnormal or atypical compared to members of a given society. The concept of abnormality is difficult to define. Examples of abnormality can take many different forms and involve different features. Applying a definition of abnormality to psychology poses a complex problem. What is normal? Whose norm? For what age? For what culture? In almost all mental disorders, we witness a failure of adaptation to the environment. In one way or another, people with mental disorders aren't adjusting well to the demands of daily life. Abnormal psychology is the scientific study of mental disorders and their treatment, which leads to the question, what are mental disorders? The answer to this question isn't as simple as we might assume, because the concept of mental disorder doesn't lend itself to a clear-cut dictionary definition. Instead, psychologists and psychiatrists have proposed a host of criteria for what a mental disorder is, and throughout history there have been various perspectives. During the Middle Ages, many people in Europe and later in America viewed mental illnesses through the lens of a demonic model. They attributed hearing voices, talking to oneself, and other odd behaviors to the actions of evil spirits infesting the body. The often bizarre treatments of the day, including exorcisms, flowed directly from the demonic model. Yet the legacy of this model lives on today in the number of exorcisms still performed around the world. As the Middle Ages faded and the Renaissance took hold, views of those with mental illness became more enlightened. Over time, more people came to perceive mental illness primarily as a physical disorder requiring mental treatment, a view that some scholars refer to as the medical model. Beginning in the 15th century, and especially in later centuries, European governments began to house those individuals in asylums, institutions for those with mental illness. It wasn't until the early 1950s that a dramatic change in society's treatment of individuals with mental illness arrived on the scene. It was then that psychiatrists introduced a medication imported from France called Thorazine into mental hospitals. It wasn't a miracle cure, but it offered a modestly effective treatment for some symptoms of schizophrenia and other disorders marked by a loss of contact with reality. By the 1960s and 70s, the advent of additional medications became the primary impetus for a governmental policy called deinstitutionalization. Deinstitutionalization featured two major components: releasing hospitalized psychiatric patients into the community and closing mental hospitals. But deinstitutionalization was a decidedly mixed blessing. Some patients returned to a semblance of a regular life, but tens of thousands of others spilled into cities and rural areas without adequate follow-up care. This lecture has three sections. First, we'll look at the DSM-5, which aids clinicians in the diagnosis of mental disorders. Then we'll look at 6 major categories of mental disorders and the symptoms associated with various diagnoses. And finally, we'll investigate the various theoretical perspectives in the treatment of mental disorders. The text identifies some common criteria that are used to diagnose mental disorders, and it takes several of these criteria to come up with a diagnosis. First, is the behavior or thought process atypical? That is it statistically infrequent? Many mental disorders, like schizophrenia, are uncommon in the population. Yet we can't rely on statistical rarity to define mental disorder, because not all infrequent conditions, such as extraordinary creativity, are pathological. And many mental illnesses, such as depression, are quite common. Secondly, is the behavior, thought process maladaptive? Does it prevent the person from successfully functioning and adapting to life's demands? Most mental disorders interfere with people's ability to function in everyday life. These disorders can destroy marriages, friendships, and jobs. Yet the presence of impairment by itself can't define mental illness, because some conditions, like laziness, can produce impairment but aren't mental disorders. Is the behavior, thought process personally distressing? The person engaging in a behavior may find it troubling. A woman who secretly makes herself vomit after every meal may never be seen by others as deviant because they don't know about it, but this pattern of behavior may cause him or her to feel intense shame, guilt, and despair. And the final criteria is asking the question, is the behavior or thought process irrational? The DSM-5, published in 2013 by the American Psychiatric Association, is the most widely used diagnostic system for mental disorders. It contains descriptions, symptoms, and other criteria for diagnosing mental disorders. Since the DSM-4, the previous version, there has been a wealth of new research and knowledge about mental disorders. There are 20 major categories in the DSM-5. 6 are covered in the text: anxiety disorders, obsessive compulsive and related disorders, depressive disorders, bipolar disorders, schizophrenia spectrum and other psychotic disorders, and personality disorders. The changes brought about by the DSM-5 have been viewed both positively and negatively. The DSM-5 made a major change in that the manual moved to a non-axial assessment system, which requires clinicians to simply list the disorders along with symptom severity and impairment. Previously, there were 5 axes that had to be filled in. Along with the mental disorder or personality disorder, clinicians had to identify any health conditions and provide a global assessment of functioning. The strengths of the DSM-5 include it provides more reliable classifications, and it includes the current state of knowledge about mental disorders. It provides a common language for clinicians and researchers, and meets insurance criteria for payment for therapy. Weakness is that it's possible that many aspects of normal behavior may now fit criteria for diagnosis of mental disorder. Some believe the addition of additional diagnoses and the changes in the descriptions of some diagnoses will lead to more people being diagnosed with mental disorders. Psychiatric diagnoses serve a couple of important functions. First, they help us pinpoint the psychological problem a person is experiencing. Once we've identified this problem, it's often easier to select a treatment. Second, psychiatric diagnoses make it easier for mental health professionals to communicate. When a psychologist diagnoses a patient with schizophrenia, she can be reasonably certain that other psychologists know what the principal symptoms are. However, on the other hand, there's concern over labeling people with mental disorders and the perceptual bias of labeling. Diagnostic disorder labels tend to lead to negative perceptions and interpretations of a person's behavior in terms of the label. Individuals can be stigmatized due to a particular diagnosis. And individuals with mental disorders are often misrepresented on television and the media. The Rosenan experiment was conducted by a psychologist named David Rosenan and has been considered one of the most striking studies in the field since then. He wanted to see if researchers could get admitted to mental hospitals when complaining of auditory hallucinations, hearing the words dull, empty, and dull. He also wanted to learn what would happen after such people were admitted if they acted normally and said that they no longer heard the voices and said they were feeling normal again. Here's what happened. The researchers, pseudo-patients, were admitted with a diagnosis of schizophrenia to mental hospitals when complaining of a single symptom of auditory hallucinations. After being admitted, they acted normally and said that they no longer heard the voices. Subsequent normal behavior was misinterpreted in terms of their diagnosis. Even when released, they carried the label schizophrenia in remission. As I've mentioned, 6 major categories of mental disorders are covered by the text: anxiety disorders, obsessive compulsive and related disorders, depressive disorders, bipolar and related disorders, schizophrenia spectrum and other psychotic disorders, and personality disorders. Now, I'm not going to cover all these specific diagnoses, and I'll just let that to your reading of the text. Most causal explanations for mental disorders are tied to the 4 major research approaches: biological, behavioral, cognitive, and sociocultural. No one approach is better at explaining all of the various disorders. The biopsychosocial approach explains abnormality as a result of an interaction among biological, psychological, and sociocultural factors. In other words, abnormal behavior can be influenced by biological factors such as genes, psychological factors such as childhood experiences, and sociocultural factors such as gender. These factors can operate alone, but they often act in combination with one another. To appreciate how these factors work together, consider that not everyone with a genetic predisposition to schizophrenia develops the disorder. Similarly, not everyone who experiences childhood neglect develops depression. From the biopsychosocial perspective, none of the factors is considered necessarily more important than another. Rather, biological, psychological, and social factors are all significant ingredients in producing both normal and abnormal behavior. Furthermore, these ingredients may combine in unique ways so that one depressed person might differ from another in terms of the key factors associated with the development of the disorder. We'll begin our tour of psychological disorders with the problems stemming from anxiety. Fortunately, most everyday anxieties generally don't last long or feel especially uncomfortable. Anxiety in small doses can even be adaptive. However, anxiety disorders are among the most prevalent of all mental disorders. They share features of excessive fear and anxiety and related behavioral disturbances. And the specific anxiety disorders differ from one another in the types of objects and situations that cause fear and anxiety. Many of us have mild fears of things like spiders and snakes that aren't really severe enough to be phobias. For a fear to be diagnosed as a phobia, it must restrict our lives, create considerable distress, or both. Phobias are indicated by a marked or persistent fear of specific objects or situations, such as snakes or heights, that is excessive or unreasonable. The anxiety and fear of a specific stimulus may be rational to an extent, but in the case of a specific phobia, the anxiety and fear are in excess of what is typical. A snake phobia that keeps someone who lives in the city from leaving his apartment is clearly disproportionate to the actual chances of encountering a snake. John Madden, former NFL coach and retired football commentator, has a famous fear of flying that led him to take a bus to the games that he broadcast. We all know the feeling of being nervous or uncomfortable in a social situation. Maybe you've clammed up when meeting someone new or gotten sweaty palms before making a big presentation. Public speaking or walking into a room full of strangers isn't exactly thrilling for everybody, but most people can get through it. Social anxiety disorder is more than shyness. If you have social anxiety disorder, the stress of these situations is too much to handle. A person may fear eating in public, rejecting all lunch and dinner invitations. You might avoid all social contact because things that other people consider normal, like making small talk and eye contact, make you so uncomfortable. All aspects of your life, not just the social, could start to fall apart. Social anxiety disorder is indicated by marked or persistent fear of one or more social performance situations in which there is exposure to unfamiliar people or scrutiny by others. Agoraphobia is characterized by a fear of being in places or situations from which escape might be difficult or embarrassing. It includes being in a crowd, standing in line, and traveling in a crowded bus or train, or in a car in heavy traffic. A common misconception is that agoraphobia is the fear of crowds or public places, but agoraphobia actually refers to a fear of being in a place or situation in which escape is difficult or embarrassing, or in which help is unavailable in the event of a panic attack. To avoid such situations, people won't leave the security of their homes. Thus, agoraphobia is a case of classical conditioning, in which the fear and avoidance response is a conditioned response to the initial panic attack. Panic disorder occurs when a person experiences recurrent panic attacks, sudden onsets of intense fear. Some panic attacks occur when a person is faced with something he or she dreads, such as giving a speech, but other attacks occur without any apparent reason. A panic attack includes symptoms such as trembling, sweating, heart palpitations, chest pain, shortness of breath, and feelings of choking and dizziness. The person is overrun with anxiety and fear. People have described panic attacks as feeling like they are dying. A biological explanation suggests that abnormal neurotransmitter activity, especially that of norepinephrine, and the improper functioning of a panic brain circuit, the fight or flight system, which includes the amygdala, hypothalamus, and some areas in the brain, are to blame. And it can occur with or without agoraphobia. A cognitive explanation suggests that panic-prone people are overly sensitive to bodily sensations and mentally dwell on them. When you worry about getting a speeding ticket, you know why you're anxious. There's a specific cause. Generalized anxiety disorder, GAD, is different from such everyday feelings of anxiety in that sufferers experience persistent anxiety for at least 6 months and are unable to specify the reasons for the anxiety. People with GAD are nervous most of the time. Certainly, we all get caught up with worry from time to time. Yet, for those who have GAD, worry is a way of life. People with GAD spend an average of 60% of each day worrying, compared with 18% for the rest of the general population. Many describe themselves as worry warts. They tend to think anxious thoughts, feel irritable and on edge, have trouble sleeping, and experience considerable bodily tension and fatigue. The next major category of mental disorders we'll take a look at are obsessive compulsive and related disorders. Just about all of us have had a thought or even a silly jingle that we just couldn't get out of our heads. People with obsessive compulsive disorder know all too well what this experience is like, except their symptoms are much more severe. Obsessive compulsive disorder occurs when a person experiences recurrent obsessions or compulsions that are perceived by the person as excessive or unreasonable and cause significant distress and disruption in the person's daily life. They typically suffer from obsessions, persistent, intrusive thoughts, ideas, impulses, or images that cause anxiety. They usually center on unacceptable thoughts about such topics as contamination, aggression, or religion. For example, individuals with OCD may be consumed with fears of being dirty or thoughts of killing others. Unlike ordinary worriers or people who experience compulsions that aren't especially disturbing to them, such as checking repeatedly to see whether a door is locked, people with OCD typically are disturbed by their thoughts and usually see them as irrational. Now, most OCD patients also experience symptoms closely linked to obsessions, namely compulsions, which are repetitive and rigid behaviors that a person feels compelled to perform to reduce anxiety. Repetitive behaviors are mental acts that they undertake to reduce or prevent distress or relieve shame and guilt. Can include repeatedly checking door locks, windows, electronic controls, and ovens, repeatedly arranging and rearranging objects, washing and cleaning repeatedly and unnecessarily, or even counting the number of dots on a wall, or touching or tapping objects. The next major category are depressive disorders. Everyone feels blue sometimes. A romantic breakup, the death of a loved one, or a personal failure can cast a dark cloud over life. Sometimes, however, a person might feel unhappy and not know why. Depressive disorders are mood disorders in which the individual suffers from depression, an unrelenting lack of pleasure in life. Depressive disorders involve the presence of sad, empty, or irritable moods, accompanied by somatic and cognitive changes that significantly affect the individual's capacity to function. Now, some individuals experience what is classified as a major depressive disorder, which occurs when a person has experienced one or more major depressive episodes, and it's often referred to as unipolar depression or a unipolar disorder. It's important to note that feelings of sadness and downward mood following stressful events are understandable and normal, and given time, usually are self-correcting. Such feelings under such circumstances do not necessarily indicate a major depressive disorder. A major depressive episode can be characterized by a variety of symptoms. Feelings of intense hopelessness, low self-esteem and worthlessness, and extreme fatigue, dramatic changes in eating and sleeping behavior, an inability to concentrate, and greatly diminished interest in family, friends, and activities for a period of 2 weeks or more. Just as we all have down times, there are times when things seem to be going phenomenally well. For individuals with bipolar disorder, the ups and downs of life take on an extreme and often harmful tone. Bipolar disorder is a mood disorder which occurs when a person's mood takes dramatic swings between depression and mania, with recurrent cycles of depressive and manic episodes. A manic episode involves a period of at least a week of abnormally elevated mood in which the person experiences such symptoms as inflated self-esteem with grandiose delusions, a decreased need for sleep, constant talking, distractibility, restlessness, and poor judgment. The person has tremendous energy and might sleep very, very little. A manic state also features an impulsivity that can get the individual in trouble. For example, the sufferer might spend his life savings on a foolish business adventure. The next major category are the schizophrenia spectrum and other psychotic disorders. A psychotic disorder is a disorder characterized by a loss of contact with reality. We're only covering schizophrenia from this category. More people are institutionalized with schizophrenia than any other disorder. About 1% of the population suffers from schizophrenia. The onset tends to be in late adolescence or early adulthood and strikes men earlier and more severely. A higher incidence occurs in lower socioeconomic groups and for people who are single, separated, or divorced rather than married. It is difficult to imagine the ordeal of people living with schizophrenia, who comprise about half of the patients in hospitals. The suicide risk for individuals with schizophrenia is about 8 times that for the general population. For many with the disorder, controlling it means using powerful medications to combat symptoms. The most common cause of relapse is that individuals may stop taking their medication. They might do so because they feel better and believe they no longer need the drugs, or the side effects of the medications are simply too unpleasant. The DSM-5 definition of schizophrenia says there must be at least 2 of the following symptoms present most of the time during a 1-month period. Hallucinations, which are sensory experiences that occur in the absence of real stimuli. Hallucinations are usually auditory. The person might complain of hearing voices, or visual, and much less commonly they can be experienced as smells or tastes. Delusions, which are false, unusual, and sometimes magical beliefs that are not part of an individual's culture. A delusional person might think that he is Jesus Christ or Muhammad. Another might imagine that her thoughts are being broadcast over the radio. Disorganized speech, sometimes called word salad, where words are just simply mixed together without any meaning. There can be disorganized or catatonic behavior, or negative symptoms such as loss of emotion, sometimes called flat affect. They may experience a lack of positive emotional experience in daily life and show a lack of ability to plan, initiate, and engage in goal-directed behavior. The symptoms of schizophrenia have been classified as positive symptoms or negative symptoms. The positive symptoms of schizophrenia are marked by a distortion or an excess of normal function. They are positive because they reflect something added above and beyond normal behavior. Positive symptoms include hallucinations and delusions. Whereas schizophrenia's positive symptoms are characterized by an excess of normal function, the negative symptoms reflect social withdrawal, behavioral deficits, and the loss of or decrease of normal functions, things that have been removed. A popular biopsychosocial explanation for the cause of schizophrenia is the vulnerability stress model, which contends that genetic, prenatal, and postnatal biological factors render a person vulnerable to schizophrenia, but environmental stress determines whether it develops. This suggests a person's level of vulnerability interacts with the stressful social cognitive events in their life to determine the likelihood of schizophrenia. This disorder does tend to strike in late adolescence and early adulthood, periods of unusually high stress levels. Psychologists used to explain schizophrenia as rooted in an individual's difficult childhood experiences with parents. Such explanations have mostly fallen by the wayside. We'll end our tour of the major categories of mental disorders by looking at personality disorders. Most of us are accustomed to thinking of ourselves as one coherent, unified identity. But some individuals, especially those with personality disorders, experience a serious disruption in their thoughts or behaviors that prevents them from experiencing a healthy, consistent identity. Distinguishing normal variations in personality and sense of self from personality disorders isn't easy because we all have our own personality quirks. All the psychiatric conditions, personality disorders are historically the least reliably diagnosed. They are characterized by inflexible, long-standing personality traits that lead to behavior that impairs social functioning and deviates from cultural norms. Personality disorders usually begin in childhood or adolescence and persist in a stable form throughout adulthood. They occur in an estimated 9% to 13% of adults in the United States. They are fairly resistant to treatment and change. And there's an overlap in symptoms among the personality disorders, which leads to the difficulty in making a correct diagnosis. Sometimes individuals will be diagnosed with more than one personality disorder. The final section of this lecture is a brief overview of the treatment of mental disorders, looking at biomedical therapies which involve the use of biological interventions, such as drugs, which we'll focus on, and psychotherapies, which involve the use of psychological interventions. Drug therapy is the use of medications to treat psychological problems. For virtually every psychological disorder treated with psychotherapy, there's an available medication. We'll take a look at lithium, antidepressants, anti-anxiety drugs, and antipsychotic drugs. We should bear in mind that we don't know for sure how many of these medications work. Although drug company advertisements, including those we've seen on TV, often claim that medications, especially antidepressants, correct a chemical imbalance in the brain, this notion is an oversimplification. For one thing, most medications probably work on multiple neurotransmitter systems. Moreover, there's no scientific evidence for an optimal level of serotonin or other neurotransmitters in the brain. And many medications, including antidepressants, may exert their effects largely by affecting the sensitivity of neuron receptors rather than the levels of neurotransmitters. Lithium is not a drug, but rather a naturally occurring metallic element, a mineral salt used to treat bipolar disorder. Lithium levels in the blood must be monitored carefully because of possible toxic effects. Because of lithium's side effects, anticonvulsant drugs are now sometimes prescribed for people with bipolar disorder. There are a couple of categories of antidepressant drugs that may be used. Monoamine oxidase, MAO inhibitors, break down neurotransmitters such as serotonin and norepinephrine in the synaptic gap. MAO inhibitors can have very dangerous side effects, particularly interactions with several different foods and drinks that lead to high blood pressure and possibly death. Tricyclics are agonists for norepinephrine, serotonin, and dopamine. They are neurotransmitters made more available through blocking of reuptake during synaptic gap activity. Selective serotonin reuptake inhibitors, SSRIs, are the most common antidepressant drugs that selectively block the reuptake of serotonin in the synaptic gap, keeping the serotonin active and increasing its availability. SSRIs usually take 3 to 6 weeks to begin to see mood improvement and have very mild side effects. Examples include Prozac, Zoloft, Paxil, Celexa, and Lexapro. Anti-anxiety drugs treat anxiety problems and disorders. Benzodiazepines are commonly prescribed to reduce anxiety, and they do so by stimulating and increasing receptivity for receptor sites for GABA, thereby increasing GABA activity. Examples are Valium, Xanax, and Ativan. Now, these must be carefully prescribed due to the potential for abuse. Antipsychotic drugs are used to reduce psychotic symptoms. The early antipsychotic drugs greatly reduced positive symptoms of schizophrenia, but had little impact on the negative symptoms. They greatly reduced the need to institutionalize people with schizophrenia. They produce side effects in motor movement caused by their antagonistic effect on dopamine. And some examples of these medications are Thorazine and Stelazine. The new generation antipsychotic drugs are more selective in where the brain dopamine activity is reduced. They do not produce the severe movement side effects, such as tardive dyskinesia. Tardive dyskinesia is where the person has uncontrollable facial tics, grimaces, and other involuntary movements of the lips, jaw, and tongue. And some examples of this new generation are Clozaril and Risperdal. The psychotherapies that are used to treat mental disorders include psychoanalysis, humanistic, behavioral, and cognitive. Psychoanalysis and humanistic therapies are called insight therapies because they stress that a person achieves understanding of the causes of their behavior and thinking. Behavioral and cognitive therapies are usually referred to as action therapies because they stress that the actions of the person must change for therapy to be effective. Psychoanalysis is a style of psychotherapy originally developed by Sigmund Freud. It involves the therapist helping the patient to gain insight into the unconscious sources of their problems. They believe that when clients achieve insight into previously unconscious material, the causes and the significance of symptoms will become evident, often causing symptoms to disappear. Psychoanalysts must interpret data from multiple input sources. They strive to analyze distressing thoughts and feelings clients avoid, wishes and fantasies, recurring themes and life patterns, significant past events, and the therapeutic relationship itself. The data sources include free association, which is a technique in which the patient spontaneously describes, without editing, all thoughts, feelings, or images that come to mind. The assumption is that free association will provide clues to the unconscious conflicts leading to a person's problems. Resistance is a patient's unwillingness to discuss particular topics. When a resistance is hit, it may provide clues into unconscious conflicts. Dream interpretation provides clues into unconscious conflicts, and dreams have two levels of meaning: manifest content and latent content. The manifest content is the surface, literal meaning of the dream. It is what the dreamer reports when awakening. The latent content is the underlying true meaning of the dream and is of primary interest to the psychoanalyst. And transference occurs when the patient acts toward the therapist as he or she did towards an important figure in his or her life, such as parents. Transference is like a reenactment of earlier or current conflicts with important figures in a patient's life. There are some issues with psychoanalysis. First, psychoanalysis is time-consuming because the therapist must piece together clues with only vague circumstantial evidence, and insurance companies aren't willing to pay for that much treatment. Critics also question the validity of the psychoanalyst's main construct, for example, the unconscious conflicts and their impact on behavior and thinking. In humanistic therapy, which includes Carl Rogers' client-centered therapy, also called person-centered therapy, the therapist does not attempt to steer the dialogue in a certain direction. Rather, the client decides the direction of each session. The therapist uses unconditional positive regard, genuineness, and empathy to help the person gain insight into their true self-concept. The therapist demonstrates genuineness by honestly sharing his own thoughts and feelings with the client. To achieve this goal, the therapist is non-directive and creates the conditions that allow the client to gain insight into true feelings and self-concept. The therapist establishes an environment of acceptance by giving the client unconditional positive regard and using active listening. To achieve empathetic understanding of the client's feelings, active listening is used to gain a sense of the client's feelings, and then the therapist uses mirroring to echo these feelings back to the client so the client can gain a clearer image of their true feelings. In sharp contrast to psychotherapists who hold that insight is the key to improvement, behavior therapy is so named because it focuses on the specific behaviors that lead the client to seek therapy. It's a style of psychotherapy in which the therapist uses the principles of classical and operant conditioning to change a person's behavior from maladaptive to adaptive. It uses the assumption that maladaptive behaviors are learned and must be unlearned for therapy to be effective. And some examples are counter conditioning, systematic desensitization, and flooding. Cognitive therapy occurs as the therapist changes the person's thinking from maladaptive to adaptive. It assumes that the person's thought processes and beliefs are maladaptive and need to change. The therapist works with the client in a more directive manner than a humanistic therapist would to identify the irrational thoughts and unrealistic beliefs that need to change, and then helps the person execute that change. One of the cognitive therapies is Ellis's rational emotive therapy. The therapist will show a person the irrationality of his thinking and how to make it more realistic. The therapist directly confronts and challenges the patient's unrealistic thoughts and beliefs to show that they are indeed irrational. Irrational thoughts are marked by words such as must, always, and every. Rational emotive therapy is very direct and confrontational, and Ellis taught his clients the ABC model to show them that they have the power to manage their emotions. A refers to the activating event, for example, the failure to be perfect at everything. B refers to the person's belief about the event, like feeling like a failure for normal levels of imperfection. C is the resulting emotional consequence, for example, the depression. Now, once clients learn this model in therapy, they could eventually apply it on their own. Now, according to Ellis, A does not cause C. Rather, B causes C. So clients learn that if they can change their beliefs, they can change the emotional consequences. Another cognitive therapy is Beck's cognitive therapy. The therapist works to develop a warm relationship with the person. The person is encouraged to carefully consider the objective evidence for their beliefs to see the errors in their thinking. For instance, a student who failed a test may think she blew her chance to get into medical school. So the therapist would have the student examine statistics on how few students actually have a perfect GPA and examine the GPAs of students admitted to medical school. Is psychotherapy effective? Before the mid-1970s, there was considerable controversy regarding whether psychotherapy was effective at all. Some investigators concluded that it was virtually worthless, whereas others concluded the opposite. Beginning in the late 1970s, a scientific consensus emerged that psychotherapy works in alleviating human suffering, a conclusion that holds to this day. The effect of psychotherapy had to be shown to be statistically significantly greater than that due to spontaneous remission. Spontaneous remission is getting better with the passage of time without receiving any therapy. A meta-analysis of 475 studies involving different types of psychotherapy revealed that psychotherapy is effective. A meta-analysis involves the pooling of results from a large number of studies into one analysis. And no one particular type of psychotherapy, however, is superior to the others. These two normal distributions summarize the data of a meta-analysis of 475 studies on the effectiveness of psychotherapy. They show that psychotherapy is effective. The average psychotherapy client was better off than 80% of the people not receiving therapy. You can see how the orange bell curve has slid over toward the good outcome.